This video will discuss respiratory volumes and capacities. It's going to be a very brief discussion because you have a virtual lab that is also going to accompany your study of this. We can measure pulmonary ventilation with a device called a spirometer, and it gives us clues about the respiratory health of our patients. You're going to complete a virtual lab where you have the patient measure his pulmonary ventilation. And I'd just like to introduce some of the vocabulary that accompanies that. So the term respiratory volume is used for the measuring of air associated with lungs at various points in inhalation and exhalation. So I'd like to just walk through some of these volumes. Tidal volume is the term we use to describe the air that's entering the lungs and exiting the lungs during normal quiet breathing or eupnea. Your tidal volume is about 500 mLs, and this would just be your regular ventilation. We then have an inspiratory reserve volume. This is what happens if we keep inhaling past our normal quiet breathing. So a deep inhalation or forced inhalation, we could bring in another up to about 1300 mLs of air. Expiratory reserve volume is what would happen, or the air that we would move if we forcefully exhaled past our quiet exhalation. So about another 1200 mLs. And residual volume here is the amount of air that's in the lungs that never enters or leaves. Because your airways are an open space, much of your structure of your airway is composed of hyaline cartilage. Your alveoli of your lungs stay inflated always because of that slightly negative interpleural pressure of the pleural membrane. We have some amount of air that just always is left behind after we exhale. Total lung capacity would be the sum of all of these. So how much air you can hold after a forceful inhalation. And then vital capacity is the sum of all of these except the residual volume. So this is how much air you can actually move in and out of your lungs, because you can't move that last 1000 mLs of air. Making a quick reference to clinical disease, pulmonary diseases can reduce the rate of gas exchange in the lungs, and they can do this in several ways. So first, they can change how compliant the lung is, so how elastic the lung tissue is itself, and they can change the amount of resistance or how much obstruction is there in the airways. So through doing this, they're changing how much air we're able to ventilate. When we discuss airway disease, we can categorize them as restrictive disease or obstructive disease. Restrictive disease happens when your airway is less compliant or it's more stiff, and because of this, the patient will have a reduced lung volume. So things such as pulmonary fibrosis or scarring of the alveoli themselves can lead to restrictive disease. Obstructive disease means that we have an increased compliance. So the elastic fibers are lost, and so air comes in but doesn't go back out and ends up trapped inside of the lungs. And so with that, we're not able to get rid of that carbon dioxide rich air, and we're not able to bring in new air because we're already full of air. So things such as emphysema or asthma could lead to obstructive disease. Okay, so that's a very brief discussion of pulmonary or respiratory volumes.